the great Mohit, who helped me write these cases today. Big interest in clinical reasoning and medical education, and just delighted to be here again.
Very nice. I'm KeAndrea Titer, I go by Kiki, also junior faculty at UAB, having the pleasure to work with the great Alonso Heudebert, as well as the great Dr. Rob Centaur. Essentially, I have an interest in diversity and inclusion, as well as physical exam teaching, and help run a grant here focused on that, as well as a residency educational track that focuses on physical exam teaching. And once as well, happy to be here.
Great. And Mohit and Alonso have prepared some cases for us for another one of the great night float calls. It'll either be the patient's heart rate is too high or the patient's heart rate is too low. So Mohit, take it away.
Sure. I think we have one thing to pull up first before we dive into a case. Our wonderful friends at the Clinical Problem Solvers have this great schema for tachycardia, and we just wanted everyone to take a chance to absorb this and kind of mindfully walk through this so that it can help you through most of the cases coming forward. Yeah, I'm seeing something that, yeah, it's not going to help you for bradycardia, but it'll at least help you for tachycardia. And Alonso, I don't know if you want to maybe touch base on any of these topics here, but
I'll touch it briefly, if y'all don't mind, just for our medical students and kind of junior learners who are here. I think getting calls for tachycardia and bradycardia are exceedingly common in the night float setting, and figuring out how to kind of stepwise approach this in a way that is both rapid and inclusive of pathologies that you want to catch is important. So I think the things you need to keep in your mind when you get calls like these is one, like we always say, check your own pulse, make sure you're calm, but be prepared, because these are situations where you may end up having to, say, shock a patient, or you may have to push some intravenous meds rapidly. So this is a wonderful schema by Clinical Problem Solvers that it echoes a lot of what folks typically talk about. And a lot of the kind of higher level knowledge can be distilled into a simple algorithm of when you get a call for a tachyarrhythmia. You just have to ask yourself a couple of simple questions. One is the QRS wide or narrow? And two, is this a regular or irregular rhythm? And I'm not going to go blow by blow over everything you see here, but as you see, that kind of quickly siphons you off into a couple of different areas with different kind of treatment pathways. And we're hoping to explore that a little bit more in depth as we go through the cases.
Okay, so why don't we start? So the first case is Mr. Alfred Hitchcock. He's a 66-year-old gentleman. He has a history of ischemic cardiomyopathy with an ejection fraction of 35%. He has paroxysmal AFib. His CHADS-VASc2 score is 4. He's on apixaban. He has hypertension, and he's admitted to medicine for management of subacute dyspnea and palpitations that have been ongoing over the past 3 weeks.
Okay, so, Kiara, if there's anything that you didn't understand that he said, make sure that he clarifies it for you.
Well, I understand everything.
Good.
Thank you.
You're given report from the day team that he is admitted for acute decompensated heart failure, likely due to the fact that he's been eating a lot of salty foods during the pandemic. His EKG reportedly on admission is normal sinus rhythm. He's not really been that active over the past 3 weeks due to the pandemic and because of his dyspnea, so he's been eating a lot of TV dinners on the couch. They're diuresing him, and they mentioned to you that there's nothing really to do overnight. He's not on oxygen, and his initial chest x-ray showed no pulmonary edema. So as the team leaves for the day, right as they hit the elevator, you get a call from the nurse that the patient is having acute onset shortness of breath and feeling like his heart is racing. He has no chest pain, but describes palpitations to the nurse. And I'll stop there.
Okay, Kiara, what do you want to do?
Okay. So when there is an arrhythmia, first I want to know if this patient is compensated or not, because the treatment will depend on this. So as this patient is on acute dyspnea or palpitations, when I hear about dyspnea, maybe this patient with heart failure, I believe, and a cardiovascular past medical history, I'm concerned of um, a new AFib that is descompensating this patient and is causing dyspnea. Also, some other symptoms that can be happening in this patient with this AFib maybe can be causing a syncope or many other things. So I will like to act fast so this patient will go okay. And as this is AFib, I don't know the exactly management, but I believe he needs a cardioversion.
Okay, so that's a great start, but I think you need a little more than that. So, Kiki, why don't you be Kiara's partner? And we're going to let, since Jacob made all these wise comments, he has to work with Alonso.
Poor thing, poor
At the
thing.
fuzzy end of that particular lollipop.
You check my pulse, I'll check your pulse.
Yeah, Kiara, I think you're onto a great start. I mean, I think important things to recognize about this case is that, as you mentioned, the patient has heart failure. He's coming in with what seems to be an exacerbation, and he has AFib. And it seemed before that his initial imaging didn't show any signs of edema, although he did have some shortness of breath. But now he reports his edema, or his breathing appears to be worse than what it was when it came in, rather acutely. And so we have to think about what changed. And if the patient is telling us that he's having palpitations, and that could mean that his heart rate is the cause of that, elevated heart rate is the cause of that. So you mentioned cardioversion, which I think is an interesting point. We want to see if the patient is hemodynamically unstable before we make a decision on cardioversion. And I'll pause there and see if Alonso wants to jump in about some things that we look for to check for kind of instability.
Fantastic, Kiki. So, Kiara, I'm so glad you brought up cardioversion, because I think it's something that as overnight attendings in the hospital, you need to be prepared to do, because that time will come. But before you get to the point of cardioverting, I think we got to have a closer assessment of the patient. And what I mean by that, vital signs are vital, right? So when you get a call like this and the nurse is concerned, the first thing I do is ask the nurse to get a set of vitals as I'm walking into the room. And oftentimes that this judgment can be made with just a little bit of cognition and one finger to the patient, right? Touching the patient in one spot. And basically what I mean by that is you need to find out if this person is hemodynamically stable or unstable. Are they mentating well? So if you walk in the room and they're telling you, doc, my chest is hurting, they take the blood pressure, there's a stable blood pressure, you have some time to think, and you may be able to avoid cardioverting. And there's a lot of reasons why we don't want to immediately cardiovert someone, especially someone who's got a history of AFib in the past. There's always the risk of embolizing a clot in the heart. So step one is kind of doing that initial evaluation. And when I say lay hands on the patient, we don't need to make this an entire discussion about shock, but that's where you kind of lay your hands on the peripheral extremities and get a sense of how well they're perfusing. So for me, going to the bedside, getting a set of vitals, talking to the patient, and touching the patient's extremity is going to be the very first step in that kind of immediate pathway. But I think it's important, Kiara, what you brought up, that you need to be ready to shock these patients, because that time will come.
So Jacob, let's revisit this. The patient is checked out as being in sinus rhythm. So the patient has a history of AFib, but the EKG or admission is reported as sinus rhythm. And now we have palpitations. So what's the first thing that you would do at the bedside?
Yeah, so I mean, like Dr. Heudebert said, I think the first thing is I want vitals while I'm on the way. The biggest question to me is this patient hemodynamically stable? Can they sit there and talk to you? Are they having some new substernal chest pain? I guess the things that come up in my mind with this patient is, are they having palpitations? Do they feel like their heart is racing? Do they feel like their heart is skipping beats? Not like that's an extremely specific or sign, but I guess my concern is, they have a history of AFib. Is this paroxysmal AFib and they're having a heart failure exacerbation that threw them into AFib with RVR? Or if they've had, HFrEF, is their HFrEF ischemic? I mean, is this patient in VTAC or a VFib right now that's going down? So I guess that's the first thing I would want to know is, what does the patient look like? What is their blood pressure? And I feel like that would tell me a little bit more about how much time I have.
Dr. Stentor, I think, one of the things that you're really getting at here is kind of the importance of physical exam. And Alonso mentioned this about touching the patient's extremities. You can also check the patient's pulse, see if it's regular or irregular.
Thank you. I've been waiting for someone to say
I
that.
figured you were getting there. But yeah, I mean, we don't know if this patient's AFib is paroxysmal. It seems to be, sometimes things get carried over in the chart where a patient had a history of AFib and then they got an ablation, they don't have AFib anymore, and we don't get that minor detail, but now we're coming in palpitations, we automatically think it's AFib. It may be something else, as Jacob mentioned, maybe VTAC, depending on if that's new occurrence for him. And so just getting a simple pulse could tell you a lot of information in a few seconds, in addition to touching the patient's extremities to eval for perfusion.
Yeah, so I was actually, let me throw this out here because I haven't done night float ever in my life, because there was no night float back when I was an intern, but I was on a lot of nights, but I wasn't floating. So what I was hoping, and we're starting to get to the physical exam, but there's a complaint about dyspnea and there's a complaint about palpitations. So absolutely, I want to see if the patient's in shock. If the patient's not in shock, I want to feel the pulse, but I want to listen to the heart and the lungs, because by listening to the heart, a lot of times I can figure out if the patient's in AFib just by listening to the heart. And if I know it's AFib while I'm waiting for someone to get me an EKG, and someone in the chat asked the really smart question, is this patient on telemetry? Can you get a rhythm strip? That would really help. And if not, get someone to get a machine in so we can get a rhythm strip, and listen to the lungs. So we know the patient did not have pulmonary edema, but could this patient have flash pulmonary edema? So I agree with the start of everything, but you really have to examine both the heart and the lungs in this situation, I think, and figure out what does palpitations mean? Can you feel it? Can you hear it? I don't know. Am I getting too excited?
No.
Is that too pedantic?
Spot on.
Mohit, was that too pedantic?
No, not at all. I think that's a good segue actually to getting some of those answers.
Yeah.
So in terms of vital signs being vital, he is afebrile. His heart rate is bouncing around between the 150s and 160s. His blood pressure is 102/64. His respiratory rate is 22, and he is satting 92% on room air. In terms of exam, Mr. Hitchcock is in moderate distress. He's sitting upright in bed with hands on his knees. His cardiopulmonary exam demonstrates an irregular rhythm and diminished breath sounds with some crackles at the lung bases bilaterally. Otherwise, the exam is negative for any lower extremity edema. His extremities are warm and well perfused.
Is he screaming the birds?
He's not screaming the birds, but he's definitely huffing and puffing.
The reason I said that, for those of you who don't know Alfred Hitchcock, that's a famous line from one of his movies. He was a very famous director of sort of very much thriller, nerve-wracking movies. And one of them, there was these birds that kept attacking. I don't know. I have looseness of association in case Alonso wants to prescribe something. Okay, KeAndrea, now that you have this information, what are you thinking?
Okay, So to go in order, his heart rate is 150 and 160. This is kind of a heart rate for a AFib maybe. Also, his blood pressure is low, but considering that he is a hypertensive patient, this blood pressure should be higher. So maybe he is hemodynamically unstable. Also, his saturation is not that elevated; it's 92%. Um, what I during exam, hearing crackles at the bases make me think about a pulmonary edema, and maybe this pulmonary edema is triggered by an AFib too. And well, when I hear a irregular rhythm, I'm also thinking about an AFib.
So, what do you want to do at this point? Do you want to find a resident, or you ready to take action? And
Um,
Jacob will tell you that finding a resident is never a bad idea when you're an intern.
well, so I'm a medical student. Maybe I can find an intern.
Good idea. Okay, so why don't you call your intern? Jacob, you're the intern.
Okay.
Help her out.
Yeah. So when I see it, you're absolutely spot on. So irregular rhythm. It seems like it's AFib RVR. And this patient, with someone who has a heart failure with an ejection fraction of 35%, many of these people may not mount an extremely like impressive blood pressure by any means. So it would be nice to know the baseline blood pressure if this was a huge drop, like you mentioned. This is kind of on that borderline of, is this hemodynamically unstable? Is it heading in that direction? I think at this point, it would be really good to hook this person up to a monitor and put pads on this person, and definitely assess this rhythm. Because I think going forward, if the blood pressure goes any lower, if you start going into the 90s and systolics, absolutely, I think a cardioversion is right for this patient. Otherwise, I think if he stays where they're at, or has a little bit better blood pressure, I think we can look at IV medications first before shocking.
And what IV medications would you want to use?
Yeah, so I'm definitely most familiar, or just have like a bias towards IV metoprolol. I'm not a big fan of IV DILT, just because metoprolol has better data as monotherapy to break AFib rhythms and keep people rate controlled. It has less chronotropic and inotropic effect, negative inotropic effect on the heart as diltiazem. So I would have a preference to use that. However, in the setting of someone who's teetering on the borderline of hemodynamic stability, another option that we don't typically go to first is amiodarone, but that is something you could consider in this patient. But I think just shooting from the hip, I would do 5 of IV metoprolol and see how he does.
Okay, so Jacob has done all this, and he finally decides to call you Kiki. So
No, I mean, Jacob, I think you and KeAndrea are both spot on. We were mentioning in the chat, what is his baseline blood pressure? As you mentioned, a lot of these patients with advanced heart failure don't have a strong blood pressure to begin with. And a lot of people mention what medications is he on already for goal-directed medical therapy, which we tend to continue in patients that are coming in with an exacerbation. So it'd be helpful to know what he's on. This patient, it's kind of, is it the chicken or the egg? Is it the heart failure that's getting worse is causing the AFib that you need to treat and lowering the blood pressure? Is it the AFib that's driving this? We think it's mostly the AFib. Maybe I'm a little cavalier, but I would go ahead and give this patient IV metoprolol, just one dose. It acts quickly. It doesn't last very long. It's definitely, I think, a better medication to trial and see if we can decrease the rhythm and see if that actually increases the blood pressure. But I agree with you. This is not a patient you kind of lay eyes on, order metoprolol, and walk away. This is a patient you're going to ask the nurse to bring the crash cart nearby just in case. You're going to have this patient hooked up to a continuous monitor. You're going to watch the nurse give them metoprolol, have them check the blood pressure within 5 minutes, and again within another 15 or 20 minutes to make sure that things are staying stable and that the patient is not decreasing or worsening, I should say. And you're also going to have this patient attached to a continuous pulse oximeter to make sure that they aren't having worsening hypoxia. So those are some of the things that I would do if I were in the situation, getting that night float page.
So one of the things I love that you mentioned, Kiki, is it depends upon what medications he was on. And so you hope that the sign out gave you the medication list that you can quickly look at and see what the patient's on. Otherwise, you're going to have to go to the trouble of trying to figure out what he's on before you decide what medications, because that'll change things. Now, you would have thought that Mohit would have told us that, but you know, what does he know? He was an intern and Alonso was teaching, and we can't expect.
Not good. Not good.
Blind leading the blind.
Yeah.
So, do we know what medications he was on? And first of all, how would that influence us? So, KeAndrea, how might what medications he's on influence what we're going to do at this point?
In example, if he's on a beta blocker, maybe we can we have to take that in count. Also, I actually don't know if this at this point is correct to control rhythm or control the rate. I don't know what does he take to control his hypertension and his heart failure. I don't know if he takes I don't know the word in English, the renin-angiotensin inhibitors.
So either an ACE inhibitor or an angiotensin receptor blocker.
Yeah, or a beta blocker or a calcium antagonist blocker. So that will have to take in count.
Right. You would think that if he has an ejection fraction of 35%, and he had AFib and he's on apixaban for his AFib, that they probably were also treating his heart failure. And so
Yes.
you would think he'd already be on either metoprolol or carvedilol,
Yes.
or maybe bispropolol, although I've never seen anybody on bispropolol, but I know that some people use it elsewhere. And so he's already on that. That might change our approach. How would that change your approach, Jacob? Let's say you found out that he was on carvedilol.
That makes me a lot more comfortable with pushing IV beta blockers, because I think the rule of thumb that I learned was if somebody's not on a beta blocker and they're in acute decompensated heart failure, do not start beta blockers. So that's somebody you might kind of step back and reassess need for shock, or versus maybe an amiodarone or digoxin, something that has just less negative effects on this patient's blood pressure.
Alonso, we've let you be quiet for a few minutes.
I've been wanting to say stuff for a while here. The discussion here has been absolutely fantastic. And like you were keen in on, Dr. Bob, the exam is really helpful here. So the patient is well perfused and seems to be mentating well. Those are all signs towards we're not near circulatory collapse. The only kind of point against it is we have new onset pulmonary edema. And what I've loved about the discussion so far is what is the blood pressure historically? And I don't want to relitigate that, but just to let you guys know that never forget that folks with bad heart failure sometimes are very reliant on that atrial kick to provide forward flow. And that might be what he's losing right now with his RVR. So I couldn't agree more with pushing metope. That's what I would do in this guy. He's mentating well, he's perfusing, but again, cautiously and next to the patient. The other thing I just wanted to bring up briefly, if you allow me, Dr. Centaur, there's been a lot of discussion about diltiazem in the chat. And one of the things I'll mention is diltiazem, I don't know why, but works a treat for me every time I've done it. I very rarely push that medication in folks with heart failure, just because long-term use of calcium channel blockers for AFib and someone with heart failure portends some pretty nasty stuff down the road. I think in the acute setting is probably okay, but that's generally why I tend to reach for the beta blocker first.
Let me just give you some historical perspective. When beta blockers first came out, when propranolol first came out, I was actually a senior resident. We were told to never use them in heart failure or asthma. We still don't use them in asthma. But it was a while before we found out that they actually can be safely used in heart failure. But they are negative inotropes. But that's okay, because they do so many positive things about the neurohormones. So Mohit, can you give us some of the information that that the hurried group did not give us when they left for the elevator?
Yeah. So in terms of baseline blood pressure, well, we can do meds first. I'll let them type it out first. The med list. So on aspirin 81, on atorvastatin 80, on a carvedilol 12.5 BID, also on lisinopril 40 milligrams daily, and then the apixaban. Otherwise, no other medications to mention, and all those medications have been given during this hospital stay. Baseline blood pressure is in the 130s over 80s.
So he's not been on a diuretic.
He's not been on a diuretic yet. There seems to have been some type of transition error when they went from the emergency room up to the floor, that they didn't get a diuretic, and it didn't look like it was on his med list at home.
Some patients with heart failure don't need a diuretic.
Yeah.
If they're not volume overloaded.
And he was taking in a lot of salt the past 3 weeks in the HPI, so that could have tipped him over too.
Now, let me just throw in one thing that I would do. This is very old school. Has he been to your hospital before?
Yeah.
Okay. I would look to see what the weight was when he left and what his weight is now. That's really easy to do. And I can't tell you how many times just checking the weight gives you valuable information. It gives you valuable information on volume overload, and gives you valuable information on volume contraction. And it costs almost no money.
Yeah. So last time he came into the hospital was about 6 months ago, right before the pandemic. He weighed about 210. Today he weighs about 225.
Okay. So how do you like that, KeAndrea?
So we use kilograms in Peru, but I believe that he is.
Okay, I can convert that for you. He went from about 94 kilograms to 100 kilograms.
Okay, so I don't know if he gained weight due to something, but as he is a heart failure patient and many other cardiovascular disease, maybe he is retaining some water, or that water is going to the lungs or to any some edemas. I haven't checked him. I don't know how he is. So maybe he has some edemas or pulmonary edemas. Also, with that, we now have his baseline blood pressure. So it is with that, and now he having 102/64. He is with a less blood pressure than he usually is. So we can be thinking about some kind of instability. About his medication, I also was surprised that he isn't on some Lasix or any diuretic. Maybe this can be the cause of his water retention. So I wonder if this patient has a compensated heart failure or not, if this heart failure is controlled, and if not, maybe this can be the cause and not the AFib that caused the exacerbation. Maybe this the heart failure is exacerbation that can be causing this AFib.
You want to call your intern for help?
Yeah. So seeing this weight gain, absolutely. I would love to know what the BMP looks like, just to see what this guy's kidney function is before he gets a dose of Lasix. For someone who's Lasix naive, I think 40 of Lasix would be a good starting point, unless this person has very poor kidney function, may require more. But I absolutely agree. I think a lot of this is AFib RVR that's induced from volume overload in the setting of a decompensated heart failure.
So can we help our intern out, Mohit?
Yeah, sure.
He's got an electronic medical record. He can find it, so you can't hide it from him.
So I didn't jot down every specific, but his electrolytes on admission were all within normal range, and his creatinine was his creatinine clearance is well above 60 at his baseline. He, in terms of, I think someone asked for maybe a NT pro BNP, that was mildly elevated at 500. There was no real baseline BNP to compare in the system.
Some people want to know if he had peripheral edema.
He did not have peripheral edema on admission, nor did he have peripheral edema on assessment when we were called overnight. And someone, I think, in the chat also asked if he had a jugular venous distension. He had a pretty large neck, so it was hard to tell, but I did not see any jugular venous distension.
Okay, so write the orders, Jacob, and Kiki's going to come by and either give you a thumbs up or tell you that you have a learning opportunity.
Okay. Okay, so one like we talked about, I think 5 of IV metoprolol is the first thing I'm giving this guy. I'm watching. I want to see what his heart rate does over the next 5 to 10 minutes. If it doesn't respond, I'd probably do another 5 of IV metoprolol before I try to move to something else. Seeing that he's definitely volume overloaded in his lungs, it seems more of maybe an isolated left-sided heart failure. If he doesn't have any peripheral signs of edema, I think he would benefit from 1 dose of Lasix. So I think 40 of IV Lasix would be my next medicine to give at this point. And then definitely strict eyes and O's and watch that. But I think the big picture for me right now acutely is still going to be the AFib RVR.
How fast do you think the furosemide is going to work?
It's going to, I would really reassess urinary output in 1 hour after giving dose.
So you give, let's say you give the furosemide and 10 minutes later he's breathing better. How did that happen? Because that does happen.
It definitely has a vasodilatory effect on the pulmonary arteries.
Nice.
Or veins.
Yeah, it's really, it's one of the most magic things in medicine. So, Dr. Titer, how did your intern do?
I think he did great. I applaud his plan, and I co-sign to it. I think, thinking globally, when you get these pages and you go examine these patients, you want to think about, what am I going to do in the next few minutes? What am I going to do in the next hour? And then what am I going to do within the next couple hours or overnight? And by do, I mean either do for the patient, give the patient, or assess by getting labs and other information, imaging as well. So Jacob, I think you kind of hit the nail on the head. Certainly immediately, like we said, we're going to get vitals. We're going to examine the patient very quickly. We're going to push our IV medication of choice. Some people prefer metoprolol, some people prefer diltiazem. I think there's certainly arguments for both. And that's what we're going to do in the first few minutes. And also get an EKG. I think thinking within an hour, like you said, we're going to give the patient Lasix and make sure that they're diuresing. We're probably going to get a chest x-ray and examine for pulmonary edema as well. We're also going to order a stat troponin as well and check for any signs of heart damage. And I think in the next few hours overnight, we're going to come back and assess this patient very shortly. Make sure they're breathing okay, make sure their tachypnea is improved, make sure they're still having adequate urine output. Once again, getting a fresh set of vitals. And so when you're thinking about how to manage these patients, make sure you make a little checklist of boxes you want to do for the patient, and be sure to come back and examine him.
Alonso, you helped design this. Do you have any other thoughts?
I think
I actually have one other thought. I want to see what you say.
I think they covered basically everything I would get. I would probably send a lactate off in this patient as well. Again, he looks like he's perfusing okay, but I think it's good to try to catch that incipient cardiogenic shock if that's the direction we're headed. But the troponin for sure, EKG for sure, lactate for sure, and then management wise, IV beta blocker with IV Lasix, IV loop diuretic.
So the EKG is in my mind, is for 2 different reasons. One is to establish the rhythm.
But it's also for ACS.
Somebody who goes acutely into what we think is pulmonary edema, you have to make sure that this wasn't really, could his episodes really be ischemia. We think he probably has ischemic heart disease. He's on atorvastatin. And I was taught many years ago that if this is flash pulmonary edema, you have to rule out coronary artery disease. You have to rule out an acute MI. And so I would look at the EKG, looking not just for the AFib, but even though AFib is an unusual MI rhythm, it can happen.
Absolutely.
But you don't want to miss an MI. So I think you have to also make sure that's not happening. So Mohit, why don't you wrap this one up so we can try to get another one in?
Yeah, absolutely. So all great points, and everyone thought about this so appropriately. I really applaud everyone. So the EKG, I mean, we have one that we can look at, but just briefly, it's AFib, RVR. There was no real ischemic changes, so ACS was ruled out along with troponins that were negative. When we saw him, I was also a little bit concerned about the blood pressure, especially compared to his baseline. He had already gotten carvedilol, his nighttime dose. So I didn't give him beta blocker therapy IV. I actually gave him amiodarone bolus 150. That brought his heart rate down beautifully down to like the 110s. His dyspnea almost immediately improved from that. I also gave him a dose of Lasix, like we were talking about, and Jacob, with him being naive, I did 40. He had good urine output through the night. No further episodes of dyspnea. I kind of tracked this course, and it seemed like once cardiology got involved, it seemed like the story spelled out that he was having more and more palpitation episodes over the past few weeks. And then during those episodes would get dyspnea, and that would last for some period of time and then resolve and then come back again, then resolve and come back again. So the thought was that he was having a higher burden of maybe these paroxysmal AFib events that was then leading to him decompensate more than anything else.
Did they consider pulmonary vein ablation on him?
Yeah, so I think he's going for EP follow-up for consideration of ablation.
And that's just one thing to keep in the back of your mind. In a patient like this, who, despite being on a beta blocker, has RVR, that can actually change their quality of life tremendously. So EP can really do something great. So why don't we go to number 2? First of all, can we all clap for our discussants who did a great job? And or you can do the reaction thing, and let's see, we can put the clap up on the reaction. Okay,
Sean, let's do case number 2. It's my favorite case. Dr. Centaur, we always do this. Me and Mohit get so excited, so we wrote 4 cases, and we probably should have known that was never going to happen. But this is a case
we can come back in a month and do the other 2 cases.
Right. This is a case I wrote that I'm super excited about. I really hope it works. But let's get going and get it going for you guys. So this is a 52-year-old male. He's got a past medical history of alcohol abuse, coronary artery disease, status post of PCI. Presents to the ED with acute intoxication and a syncopal event. Went to the ED, negative troponins. He's admitted to the floor for observation. He's on telemetry. Overnight, there's various calls that the patient is combative. He's ripping out IV lines. The CWAS scores are positive basically for agitation and nausea, but not for any vital signs, diaphoresis or anything like that, or delirium. But otherwise, normal vital signs, absent diaphoresis or tremor. On your 4th call related to patient, they say that—
Alonso, slow down a little bit, I think, with the typing.
Sorry, guys. So alcohol abuse, coronary artery disease, PCI, coming in with acute intoxication, syncopal event. You've had multiple calls for issues on the floor. And then on the 4th call, you actually get a call from telemetry. The patient had a 20-second run of VTAC. He denies any symptoms besides his ongoing agitation and nausea. And you're called by the nurse to assess.
You know what's so great about this case? We've all taken care of this guy.
Mm-hmm.
We know this guy very well. And this guy has not changed since the 1970s. He was coming back in the 1970s, in the 80s, in the 90s.
Absolutely. It's a tale as old as time.
It really is. It really is. So KeAndrea, we keep putting you on the spot. I know that you never have somebody like this in Peru. No, they might be drinking pisco sours, or they might be drinking just pisco by itself.
You have to come to Peru.
I've been to Peru.
Oh, really? Where?
I've been to
When?
Peru 3 times with Alonso's
Oh,
dad.
I'm sorry.
Cayetano.
With who? I couldn't listen. With who?
Dr. Santor's been with my dad multiple times to Peru.
Wow. So
My
next
dad
time,
studied at Cayetano, so they have a beautiful kind of relationship with Cayetano.
really? Oh,
Mhm.
we'd like to know more about them. So next time you come here, you can
Yeah.
visit me.
Okay. So
Okay.
so what do you want to do?
Oh, well. So alcohol abuse. I'm not that. Um, I don't know too much to be honest, but I know that that people with alcohol abuse like this, that severe like him, maybe can develop some cardiopathy, like dilated cardiopathy, and with that they can develop any kind of arrhythmias. So as we are on a arrhythmias class right now, so um, but he is developing a ventricular tachycardia, I believe.
Mhm.
So I'm concerned about this because when there's a VT, his heart can get tired and stop beating, and that's like a big concern. That's how I understand. So what I want to do is like change that rhythm, change that that rate. And also, what I will do first is, as always, see vitals, check physical exam, check pulse, if this ventricular tachycardia is with pulse or not. Um, and well, I think that's what I will do first.
Yeah, but by the time you get to the patient, he's back in sinus tach.
Yeah, I might not have been clear. This was a call from telemetry, Kiara, where there was a run, about 20-second run of ventricular tachycardia that's resolved now, but they're calling us to let us know that he had a
Oh,
kind of
okay.
long run of what we call non-sustained ventricular tachycardia.
I think it's time to call the intern because the medical student's getting nervous. So
All right.
I'd rather the
Intern was just nervous in the corner. Uh, yeah. So I guess the way I think about VTAC, I guess before I talk about kind of what I would do is 30 seconds is really the defining moment of non-sustained versus sustained VTAC, and I think can be the differentiator of how you go about treating this guy. And like you said, I kind of want to know, in somebody who's coming in has a high CY score, when did they last use, what all drugs did they use? Was cocaine in the mix with this, or is it all some type of alcohol withdrawal? Which can cause somebody to have a very high adrenergic state, causing something like this, but also the fact that this person's had coronary artery disease and a PCI, likely has some sort of myocardial scar, which can kind of be the source of this VTAC, especially if it's just a polymorphic VTAC that was tacking along. And like you, I want to know, what are his vitals look like? What does his exam look like? And does he have any raging electrolyte abnormalities that may have caused this? And then we'll kind of reassess from there.
So Jacob, you just made me very happy because you did say electrolyte abnormalities, and we all know how much I love those. So which ones are you concerned about in VTAC?
Potassium and magnesium are the main two. You could consider phos, but we always write in our note K above 4, mag above 2.
So low phos can do this also. And all of those occur in alcohol and people with alcohol abuse. So you really do need to check out the labs. So I think what you've said is this because of his heart disease, or is there some other factor going on? Kiki, you didn't design this case. Alonso did. So we're going to keep Alonso quiet for a few minutes because he knows too much. Is there anything else that you want to do in this patient?
Yeah, I think Jacob hit it once again on the head. Just thinking about what am I going to do in the next few minutes acutely for this patient. And this is a patient I would immediately, once again, ask the nurse to provide me or have vitals ready when I go and assess the patient. This is not someone you say, okay, thank you, call me if it happens again kind of thing. But after hanging out with telemetry, you would call the nurse, ask for vitals, ask the nurse, what does the patient look like? Are they alert and awake? Could you ask the patient, are they complaining of any chest pain, and try to get some information for you while you're headed up to the floor. I would immediately lay eyes on the patient and make sure they pass my eyeball test, and ask the patient just a few screener questions. Once again, what were you doing in the last few minutes? Were you having any symptoms, any chest pain, shortness of breath, anything that could let me know if they were symptomatic from this non-sustained VTAC. And then I would go to the telemetry on the unit and take a look at the strip myself. And if I needed help, I'd go to the CCU and ask the cardiology fellow to take a look at it with me. Those are just some of the things I would definitely do within the first few minutes of getting this call. And I'll pause there before we talk about next steps.
Other than the VTAC, what's the most dangerous thing that you might see on the EKG?
I think certainly if you see ST elevations, that is a huge red flag, and that's someone I'm calling a code MI, calling the CCU fellow to call the code MI and readily assess.
Okay, so let's say we don't see that. There's one other thing that you have to worry about. Jacob, what else do you have to worry about?
I guess like a long QT that could have
Absolutely.
caused
Absolutely. Because those electrolyte disorders can cause long QT.
Absolutely.
Right. So when you just hear VTAC, what do you worry? If it's a long QT, what are you worried about?
So long QT, I think low mag.
Okay, but what's the name of the how? When you go look at the strip, what are you looking for?
Yeah, is this patient in Torsades? Because that would be a completely different treatment than a VTAC.
Right. So if you're on night float, so when Kiki told you go look at the telemetry strip, she's giving you great wisdom because you don't want to miss Torsade, because you can treat it. You can fix that really quickly. So actually looking at the strip and looking at the labs is going to be really useful. Obviously, looking at the patient. So,
can I give you guys some information? There was a number of questions that came out that I want to answer.
Please.
We do have a telemetry strip for you. If you can reveal that, Sean, that'd be great. Just some questions I heard very quickly. UDS was negative. ETOH level was very high. Gentleman still acutely intoxicated. In terms of stent history, he had a bare metal stent placed years ago. He's no longer on dual antiplatelet therapy. This is a guy with poor social support, poor access, not taking any medications reliably. There was a couple of questions about a BMP, and just to kind of move things forward a little bit, he had a profound hypokalemia on initial presentation that they're trying to replete. But have been having some issues secondary to his agitation. There was a repeat BMP ordered, but the nurse hasn't drawn it yet because they still have only run a small amount of their of the K run secondary to patient issues.
And you probably don't have a mag and a FOS yet.
I don't want to give you one.
You don't want to give us one. So, KeAndrea, are you good at reading these kinds of EKGs, or do you need Jacob to help you?
I believe this is the pattern of Torsade, so I'm not that sure. Is that? So
What do you think, Jacob? Is she a star student or what?
You were spot on. Honors on this Zoom meeting.
Yeah. So, what's the treatment for Torsade?
Actually, I don't remember.
Good. Jacob's going to teach you.
Yeah. So IV mag sulfate. I wish I could tell you the dose right now, but I don't know it off the top of my head. But IV mag sulfate is going to be the thing that fixes this rhythm.
there's a wonderful podcast from the Curious Clinicians on why MAG works for Torsade. I highly recommend it. It's only about a 20, 25-minute podcast, but it's, and I can, what I'll do is after this, I'll put it on Twitter for the people who are on Twitter, the link to that podcast. And they explain exactly why MAG fixes Torsade. Now, the fact that he has low K, so if you have someone with alcohol abuse and a very low potassium, they have low magnesium, even if their serum magnesium is normal.
Absolutely.
So, Kiara, do you understand that? Do you understand why you could have a normal serum magnesium but still be magnesium depleted? I bet they taught this to you, but they may not be as obsessed with this as I am, so that they may not have stressed it as much.
I'm not that sure. I would like to learn.
Okay. Do you know why, Jacob?
I do not know why.
So magnesium is mostly intracellular. And so you can be intracellularly depleted, but have enough mag in the serum that your total body mag depleted, and that's all that matters to the heart. And so if you give mag, you drive it back into the cells. And you can be fooled on that. For years and years, we've known that refractory hypokalemia, you empirically give mag. I'm really glad you have that EKG. So I've gone crazy, Kika. I haven't given you a chance to talk.
No,
Do
you're
you
hitting
have
all
any
the
other
points I
tips?
was gonna-
I'm sure that when you're on nights on the hospitalist service that you get these kinds of calls also.
Yeah, I've had a couple of, well, I had one Torsades patient when I was in a CCU as a resident. You guys touched on all the points I was going to touch on. I think the only thing I would add is, we don't have vitals for this patient, but patients with Torsades can certainly become unstable very quickly if he's not already unstable. I'm not sure the vitals are, but this is someone, like I said, you would assess pretty quickly. You'd ask the nurse to bring the code card close by and have a low threshold to potentially shock the patient if they look like they're becoming increasingly unstable.
Alonso, you and Mohit designed this course. Why don't you do the final teaching, because I'm obsessed with finishing on time.
Yeah, absolutely. So you guys covered everything I wanted to cover. The only other things I would mention, I had read, and maybe this is untrue, Dr. Centaur, that alcohol itself causes almost a diuresis of magnesium, and that's why you see kind of low total body magnesium in alcoholics. But the point of this case was twofold. One, that our alcoholics can commonly present with hypokalemia and a normal looking serum mag, even though their mag stores are low. This can cause a prolonged QT. And just another thing, that in this case, this guy was complaining of nausea. And if we had gotten more into it, he had a kind of one of those group order sets, and he was getting some ondansetron on top of that. And basically what you have is prolonged QT leading to a Q on T phenomenon. And that's what causes Torsades de points. And Torsades is oftentimes resolves on itself. It can be kind of short runs. But you find it on telemetry, and it's something that if you don't treat, will deteriorate into an unstable rhythm and potentially kill this patient. So what happens when what do you do for these guys? You guys already covered. You replete the mag, you replete the potassium. This guy would probably require some chemical sedation, which would require some thinking about what the best way to approach it. For this guy, just, he's acutely intoxicated, having a hard time getting those meds into him. I saw in the chat some discussion about phenobarb, which works really well. Another idea would be to push benzodiazepines above and beyond the CWA protocol. This guy wasn't really in withdrawals. He was just acutely intoxicated and being a bit rambunctious. Anything else I think you guys covered most of the stuff I wanted to talk about. But correcting that underlying electrolyte disturbance, recognizing Torsades when you see it, and pushing IV mag is critical.
Okay, good. Maria put in the chat the link to the Curious Clinicians, and the chat went wild, and really liked that recommendation and just that podcast in general. It's really a great podcast, and they're the right length. They're like 20-25 minute lengths, which is really good length for a podcast. You're 100% right, Alonso. Alcohol causes both magnesuria and phosphaturia, and so that's why these people have both low mag and low phosphate. Someone like this, I would always check the phosphate today and tomorrow, because sometimes the phosphate doesn't get low until the second or third day. And low phosphate, I've had presented to me a patient who died of hypophosphatemia. It is actually really serious. I think that was just a tremendous case to remind us that, looking at the telemetry strip, and Kiki's the one who said it first, we have to look at the telemetry strip, go look at it and see what's happening. My guess is when the patient came in, that there was a prolonged QT, and we don't always pay attention to that. Mm-hmm. I think in someone who's hypokalemic, you should think about that ahead of time and start repleting mag right then, before they get Torsade. I mean, is that your opinion, Alonso?
Absolutely, and particularly in a population like this one, where it should be pretty high up in your thinking.
So, real quickly from the chat, they prepared 4 cases. Should we do another run of this in about a month or so, of the other 2 cases they've already prepared? Please let us know. Yes, please. Yes. So that'll be on the docket sometime in December. That works for people. Alonso and Mohit, you did a wonderful job of bringing very realistic cases that interns have to see. KeAndrea, thank you so much for being just a superb medical student, and you were fortunate to have a great intern who luckily does not have me as his attending this month.
The 18.
But he